So now that we have done the anatomy of the medial wall and the posterior wall of the middle ear, now let us see what the anterior wall of the middle ear is. Now the anterior wall of the middle ear is also known as the carotid wall. Now why the carotid wall? Yes, it's so obvious because the carotid, the internal carotid, is in very close relation to the anterior wall. We have already seen when we did the basics of the ear that the internal carotid, after passing through the neck, that is the cervical part, it enters the pitreous bone, that is the pitreous part of the carotid. And in the pitreous part, where it enters the pitreous part, it lies very, very close to the anterior wall of the middle ear, and that we can see, we can make out here, yes, that the internal carotid goes here, so it is in relation to which wall? Very close relation to the anterior wall. Thankfully, it is in relation to the anterior wall, not the posterior wall. Why did I say thankfully? Yes, because whenever we operate on the middle ear, we usually are associated with which wall? With the posterior wall. So thankfully it is related to the anterior wall. So we do not have to worry about injuring the internal carotid all the time. Sometimes when we operate on the anterior wall, yes, we know we have to worry about it. So what are the structures that are present on the anterior wall? Yes, there are 3 openings on the anterior wall, and all of these 3 I have already mentioned in the previous module. So let me see if you remember it or not. Yes, can you tell me the 3 openings on the anterior wall? Yes, one, we have the tensor tympani. The tensor tympani, I told you, arises from the anterior wall. It then goes, it winds around the process cochleoformis. Process cochleoformis is on which wall? Is the medial wall, and then it runs laterally to attach to the upper end of the handle of malleus, right? Yes. Tell me the second opening. Yes, again it has some tympani in the name. Yes, the chorda tympani. Chorda tympani, is that the entry or the exit of the chorda tympani? Very good, the exit. The entry is on which wall? Yes, that is from the posterior wall. And the third is the very important connection between the middle ear and the pharynx. Excellent, that is the eustachian tube. So if we draw the anterior wall, how will that be? So here this is the medial wall, and here we have the anterior wall. Now on the anterior wall, I am going to mark 3 structures. Okay, this is, I'm marking 1, this is 2, and I am marking this area as 3. Okay, so these are the 3 openings. So you tell me which one is what. Tell me 1. What will be 1? Yes, very good. 1 will be the tensor tympani. The tensor tympani. The tensor tympani arises from the anterior wall, very close to the medial wall. Why? Because it has to go to the medial wall, around the process cochleoformis it will wind, and then go to attach to, it will attach to where? Yes, to the handle of malleus, to the upper end of handle of malleus. Of malleus handle. Okay, now can you tell me 2? What is 2? Is 2 eustachian tube or chorda tympani? Yes, we can see it is present superiorly. This is the area which is close to the tympanic membrane. It is lateral. So this is going to be the chorda tympani. Yes, the chorda tympani arises from the posterior wall. We saw that. Yes, superiorly. And then it passes through the middle ear in between the malleus and the incus, just above the attachment of the tensor tympani, and then it exits through the anterior wall. So this second is the chorda tympani. Chorda tympani exit. Chorda tympani exit, and this has been given a name. This is what is known as canal of Huggier. How you can remember it? You can call it Huggier or Huggier. I prefer to call it Huggier. How I remember it is, this is the exit of chorda tympani. So it hugs the chorda tympani by. So this is the canal of Huggier. It is the exit of chorda tympani. Where's the chorda tympani going from here? Yes, it is going to the tongue. Which part of the tongue? Anterior 2/3. For sensation or for taste? For general sensation or for taste? Yes, this is for taste. So here it goes, from here it exits to the anterior 2/3 of the tongue for the taste. Okay, and what is the third? Yes, the third is the eustachian tube. Third is the eustachian tube. Now this area around the eustachian tube, this area has been given a separate name. This is what is known as protympanum. So what is protympanum? If I mark it here, this is what is known as protympanum. Protympanum. So what is protympanum? Protympanum is the area of the anterior wall around the eustachian tube orifice. Now that we have done the anterior wall, it is not that only now we know what are the structures on the anterior wall. When we started with the anatomy of the middle ear in the beginning itself, we know that the anterior wall is a common wall between the middle ear and the pharynx. So any connection between the middle ear and the pharynx is going to be on which wall? The anterior wall. The nerve that exits the ear to now go to supply the tongue, again the tongue is anterior, so it has to exit through the anterior wall, right? So we already knew most of these structures earlier. So now here I have given you one endoscopic picture of the ear, of the middle ear, and I am going to mark certain structures and you are going to quickly tell me what the structures are. Yes, and what did I tell you? Whenever any endoscopic picture is given, before you start looking for the structures, yes, definitely when you have revised so many times, you exactly know that oval window or the stapes or the round window, if you can directly identify, you can know that which part of the middle ear that is. But it is always better to go in an orderly fashion. So which ear is this that we are seeing? Yes, this is pointing towards the right. So yes, this is the right ear. And which is the anterior part? Yes, this is also pointing towards the anterior. So this is the anterior part, and here we have, this is the posterior part. This is the posterior part. Okay. So now I am going to mark certain structures and you are going to quickly tell me what the structures are. Yes, tell me quickly. 1. Very good, handle of malleus. That was easy. 2. Lateral process of malleus. 3. Yes, both malleus and incus are in the vertical plane. The stapes is in the horizontal plane. So what is this? Yes, this is the incus. This is the long process of the incus. And what is this? What is this? So yes, what is this wall that where I have marked? Is this the anterior or the posterior? Yes, this is the posterior wall, and we can see some pyramidal projection. So what is this? Yes, this is the pyramid. And if I mark this structure coming from the pyramid, what is this? Is that a stapedius attaching to this area? What is this area? This is the neck of stapes. Okay, now you are going to answer. You are going to tell me what this is. This here, this opening. What is this opening? Yes, on which the stapes is present. Excellent. The oval window. Yes, now this white arrow, tell me what this white arrow is. Yes, above the oval window, you are seeing some bulge here. See here like this. Yes, what is this? Yes, this is the bulge of the fallopian canal. Which segment of fallopian canal? Horizontal part of fallopian canal. And above that is some bulge. Then what is that area? Yes, that is the bulge of which semicircular canal? Superior or posterior? None? Yes, the lateral semicircular canal. Okay, now tell me this opening. What is this? Yes, this is the round window. And here, this is promontory. Okay, now tell me this arrow. What is this? Yes, this is the anterior part of the middle ear. So, anterior part, you are seeing some opening. What opening can that be? Yes, the eustachian tube. So, excellent. This is the eustachian tube. This is the area of the eustachian tube. The chorda tympani will pass from the posterior wall to the anterior wall quite superiorly. So that opening we'll see quite superiorly towards, yes, the lateral side, that is the towards the tympanic membrane, because it is coming very close to the tympanic membrane, and the tensor tympani will be present near the medial wall because it has to go to the process cochleoformis. Now coming to the roof of the middle ear, can you tell me the roof of the middle ear separates the middle ear from what? Where is the roof of the middle ear present? Yes, we saw that in the basics of the ear. Roof of the middle ear is present on the anterior slant of petrous part of temporal bone. Yes, and can you tell me what it is known as? Yes, the roof of the middle ear is what is known as tegument tympani. And where does this lie exactly? Yes, on the anterior slant of petrous part of temporal bone. If any infection of the middle ear through the tegument tympani goes superiorly, where does it go? Yes, it goes intracranially to involve the middle cranial fossa or the posterior cranial fossa. Yes, that is the area of the middle cranial fossa. Which lobe exactly? Yes, the temporal lobe. So that is why infections of the middle ear very commonly can lead to temporal lobe abscess. So here we have the temporal lobe. Temporal lobe. Now from the roof of the middle ear hangs down a bone. And this bone hangs down at the level of just above the processus cochleoformis. So here we have the processus cochleoformis on the medial wall. Just above it you can see a bone hanging from the roof. This is what is known as cog. This is known as cog. So what is the significance of cog? The same as what the significance of processus cochleoformis is. Processus cochleoformis is a landmark for some nerve. Which nerve? Yes, the facial nerve. So it is, the process cochleoformis is a landmark of exactly which part of the facial nerve? It is a landmark for the first genu. We saw that yesterday, that this process cochleoformis is the landmark for the first genu. Just above it is the first genu, just above it is the geniculate ganglion. So similarly, cog exactly comes up to the level of the process cochleoformis from the roof. So this also acts as a landmark for the geniculate ganglion. So whenever we have to look for the geniculate ganglion, we will see this crest of bone hanging down, and where it is ending, there exactly is the area of the geniculate ganglion. So cog is a landmark for first genu. Or we can say it is the landmark of geniculate ganglion. So many landmarks we have of the facial nerve, right? Now you tell me 4 landmarks of the tympanic segment of the facial nerve. 4 landmarks. Yes. 3 on the medial wall. Very good. Process cochleoformis. Second, oval window, facial nerve lies above it. Third, lateral semicircular canal, facial nerve lies below it. Yes, and now I am telling you one landmark which is coming from the roof. What is that? Cog. So can you imagine so many landmarks we have made for identification for the facial nerve so that we do not miss this nerve? Yes, it runs in a bony canal. So the chances of injuring it is not very high, but still sometimes the bony canal can be dehiscent at some places. It can be gaping at some places. So in any case, we do not want to miss the facial nerve. We do not want to injure it. And also it is also possible that because of some disease, the facial nerve canal, the fallopian canal has got eroded. So in that case, again, we do not want to injure the facial nerve. So whenever we are operating on the middle ear, we have to be very careful where we are going to see the facial nerve, and that area we have to operate very, very carefully. Don't think that you will operate the ear and you have done a wonderful surgery, and after the surgery the patient has come out with a facial nerve palsy. That is not at all acceptable. That will be for life. Yes. So that is why we have so many important landmarks. So now starting with the floor of the middle ear. The floor of the middle ear is again a very, very important area of the middle ear. It is a very important wall of the middle ear. Why? Because it separates the middle ear from very, very important structures which are lying in the base of skull. Yes. Is the floor of the middle ear also base of skull? Yes, we know that the roof of the ear as well as the floor of the ear is both base of skull, because the ear is like a tunnel inside the temporal bone. So this part of the base of skull where the middle ear lies, the floor of the middle ear lies, just below that is the area where the vessels and nerves, the structures that are passing through the jugular foramen, the moment they are exiting, they are lying in the floor of the middle ear area. So now coming to the floor of the middle ear. The floor of the middle ear is again a very, very important wall of the middle ear. Why? Because it separates the middle ear from very, very important structures lying in the base of skull. Base of skull? The floor of the middle ear is also base of skull? Yes, we saw that the roof of the ear as well as the floor of the ear both are base of skull, because the ear is like a tunnel in the temporal bone. And this part of the base of skull is that area where we have the jugular foramen. Yes. So what are the structures that pass through the jugular foramen? Will be the structures that will be lying in relation to the floor of the middle ear. So now I have given you everything. You will tell me now what are these structures which are lying in the floor of the middle ear. Yes. Very good, the jugular bulb. And tell me 3 nerves. Yes, the 9th, 10th, 11th cranial nerves. Yes. So we have, this is the medial wall. Here we have the posterior wall. This is the mastoid. So we know that the sigmoid sinus forms the posterior boundary of the mastoid, right? It comes down and it exits through the jugular foramen, and where it is exiting, this area is lying immediately in relation to the floor of the middle ear, and now this jugular bulb extends down in the neck to form internal jugular vein. So here we have in relation to the floor the jugular bulb. The jugular bulb. So whenever there is any tumor of the jugular bulb, it can project into the middle ear. Yes, these tumors are known as glomus, which we will do later on in great detail. But here what we are seeing is that in relation to the floor is a very, very important structure, and that is the jugular bulb. So now you will tell me 3 nerves. Yes, which 3 nerves did you tell me? We have the 9th, we have the 10th, and we have the 11th cranial nerves also lying in relation to the floor. So here what we need to know is that the ninth cranial nerve, that is the glossopharyngeal, has a tympanic branch. It also gives a branch to the ear, and this branch that it gives to the ear enters the ear through which wall? Because the ninth nerve is lying in relation to the floor, so it has to enter the ear through which wall? Yes, through the floor. So the branch of the ninth nerve that supplies the ear, that is known as the tympanic branch of ninth nerve, also known as Jacobson's nerve. So the branch of the ninth nerve is known as tympanic branch, also known as Jacobson's nerve. It has been given a name, Jacobson's nerve, and this enters the middle ear through the floor and on the medial wall, on the promontory. It forms a plexus, and this plexus is what is known as tympanic plexus. And this tympanic plexus gives a sensory supply to the ear. The whole of the middle ear, the sensory supply is by the tympanic plexus. In other words, it is by which nerve? By the glossopharyngeal nerve. So whenever there is any involvement of the middle ear, any infection of the middle ear leading to pain in the ear, that is because of involvement of which nerve? Yes, that's the question of your exam. Yes, that is because of involvement of the glossopharyngeal nerve. If there is any involvement of glossopharyngeal nerve anywhere else, glossopharyngeal nerve does not only give one branch, that is to the ear, it supplies other areas also. It comes down here from the jugular foramen and it gives the pharyngeal branches. It supplies the tonsils. It supplies the base of tongue. So if there is any tonsillitis, can there be pain in the ear? Yes, there can be referred pain in the ear. And again, that forms a very, very important question of your exams. In carcinoma of base of tongue, carcinoma of tonsil, acute tonsillitis, there is pain in the ear. Pain in the ear because of which nerve? Yes, because of glossopharyngeal nerve. So quickly tell me, glossopharyngeal nerve enters the middle ear through floor, and it forms tympanic plexus on the promontory. So that is what we need to know about the floor of the middle ear. In fact, that is what we need to know about the walls of the middle ear. So now we have completed the floor of the middle ear. In fact, we have done all the walls of the middle ear. So do you have a complete picture of the middle ear in your mind now? Yes, think of it. Yes, I will tell you the walls and things in your mind whether you know everything about it or not. The lateral wall, yes, the tympanic membrane. The medial wall, yes, that is the window to the inner ear. Yes, we know that. Yes, very good. The posterior wall, yes, we have done that so beautifully. The anterior wall, do you know that? Yes, the roof. Yes, the floor. Okay, so now keep your pens down and sit straight. Yes, okay. So quickly tell me, promontory is on which wall? Promontory. Yes, the medial wall. Pyramid, posterior wall. Processus cochleaformis, medial wall. Jugular bulb, floor. Tensor tympani. Okay, tell me tensor tympani origin. Tensor tympani origin. Yes, the anterior wall. Tensor tympani attaches to processus cochleaformis. True, false? No, it attaches to the handle of Malleus. And what does it do at the processus cochleaformis? Yes, it winds around and it takes a lateral turn. Okay, how many nerves do we have in the middle ear? How many nerves in the middle ear? 1, 2, 3, 4, 5. 3 only? Okay, which 3? Chorda tympani? Yes, the facial. The glossopharyngeal. Yes. Tell me the parts of the facial nerve. Part of the facial nerve on the medial wall. What's that known as? Yes, the tympanic segment. Tell me the landmarks of the tympanic segment of facial nerve. Processus cochleaformis, oval window, bulge of lateral semicircular canal. Yes, this is the revision for you. So you should be telling it quickly. You have to tell me. Yes. What is the part of the facial nerve on the posterior wall known as? Yes, the vertical segment of the facial nerve. Okay, chorda tympani enters the middle ear through which wall? Posterior wall. Exits through anterior wall. What is that canal known as through which it exits? Canal of Huggier. Okay, what's the third nerve? Glossopharyngeal. Glossopharyngeal enters the middle ear through floor. It forms tympanic plexus. Tympanic plexus on the promontory. Promontory on which wall? Medial wall. Okay. How many muscles do we have in the middle ear? How many muscles? Okay, 2 muscles. Which 2 muscles? Yes, tensor tympani. Tensor tympani originates from anterior wall. Okay, and the second is stapedius. Stapedius originates from posterior wall. What on the posterior wall? Pyramid. And it attaches to neck of stapes. Mediates a reflex which is known as stapedial reflex. Afferent of which is 8th nerve. Efferent is 7th nerve. So 7th nerve here is the efferent. We will do stapedial reflex in great detail later on. Okay, so we have the tegment tympani. Tegment tympani is on which wall? Tegment tympani is which wall? Yes, that is the roof. Cog. Yes, cog is a landmark for For the geniculate ganglion. That is on which wall? Yes, the medial wall. So now we know all the walls of the middle ear. We know all the important structures. We know all the important connections of the middle ear to all the around structures, all the surrounding structures. So now let us see what is inside the cavity of the middle ear. Let us have a look at the cavity of the middle ear. Now the middle ear cavity is divided into three parts. And this is divided into three parts by two lines. Two lines, the upper line, it passes at the upper border of the pars tensa, like this one. And the lower line passes at the lower border of pars tensa. Now, why is this important? Yes, why this is important is that these three parts that have been divided, they are known as, the uppermost is what is known as the epitympanum. This is known as epitympanum, or it is also known as attic. It is also known as attic. The middle part is what is known as mesotympanum. Mesotympanum, and the lowermost part is what is known as hypotympanum. Now, we know that the division occurs at the upper and lower border of the pars tensa. So, if suppose we have to go into the mesotympanum, we will have to go through which part of the tympanic membrane? Pars tensa or pars flaccida? Yes, pars tensa. So, if I go through the pars tensa, I will be into the mesotympanum. Now, I do not want to go into the mesotympanum. I want to go into the epitympanum, into the attic. Now, tell me, which part of the tympanic membrane will I have to go through? Yes, the pars flaccida, the pars flaccida. And when through the pars flaccida, when I go into the epitympanum, will I be able to access the whole of the epitympanum? Just see. No, the pars flaccida forms the lateral wall of the epitympanum only in the lower part. Only lower little part. The rest of the upper part of the epitympanum, the lateral wall, is bony. And this bone is what is known as a scutum. This bone is scutum. So what is scutum? It is the lateral wall, lateral bony wall of epitympanum. Or lateral bony wall of the attic in the upper part. In the lower part, it is formed by the pars flaccida, the Sharpner's membrane. Can you tell me that which is the more mobile part of tympanic membrane, pars tensa or pars flaccida? Pars flaccida. So, if a retraction pocket occurs on the tympanic membrane, most common site of retraction pocket will be? Yes, the pars flaccida. So, if a pars flaccida retraction pocket goes inside, it goes into which space of the middle ear? Yes, the epitympanum. And this space of the middle ear, just see here, this space of the middle ear, the retraction pocket will go here from the pars flaccida. So, this space of the middle ear, which is just next to the pars flaccida, just medial to the pars flaccida, this is the site most commonly where the retraction pockets go inside. And this has been given a separate name. This is what is known as the Prusak space. So, let me just rub all this. Yes. So, where is the Prusak space? This space where I am drawing the star. Right, this here is the star is the Prusak space. This is the Prusak space. What is the Prusak space? This is the most common site of retraction pocket. So let us see this picture. Yes. Whenever you see any picture, whatever I told you, immediately you will tell which tympanic membrane it is. Is the right or left? Yes, so this is the left tympanic membrane. This is how you revise. Whenever you see, if you say the same thing, you know it becomes so clear to you that you feel that, oh, this is so natural. What do I have to think in it? Yes, so this is the left tympanic membrane and this is pars tensa. We know that. Yes, this is pars. Above the lateral process of malleus, above the malleolar folds, this here is the pars flaccida. Yes, so if I go through the pars flaccida, where will I be? Into the Prusak space. And this bone which separates which forms the lateral wall of the epitympanum, separating the external aortic canal from the upper part of the epitympanum. This is what is known as the scutum. This is the scutum. Yes, so just see this. Can you see this? What are you noticing here? Yes, just see here. This is the pars tensa. And here in the pars flaccida area, can you see a big retraction pocket? Yes. So this space where this retraction pocket has gone into, this space is just medial to the pars flaccida. This is what is known as the Prusak space. And here we can also see that there is erosion. This yellow mark, this is erosion of the scutum. The scutum has also got eroded because of the disease. So if I ask you what the boundaries of the Prusak space will it be difficult for you to tell me? Think and tell me. I will just tell you lateral, medial, you tell what this is, what you are seeing, okay? So what is the lateral boundary? Lateral boundary is this of the Prussic space. What is that? Yes, the pars flaccida. Medial boundary is this. What is this? This is the neck of the malleus. We know that malleus has a head, so it has a neck also. And inferiorly is this. What is this? This is the lateral process of malleus. Yeah, so when you know what this space is, where it is, so do you have any difficulty in remembering the boundaries? No, you just have to have that anatomy picture in your mind and you know it. So what is the medial boundary of the Prussic space? Medial is the neck of malleus. What is lateral? Lateral is pars flaccida. And what is inferior? Inferior is the lateral process of malleus. So now that we have this cavity of the middle ear in front of us, can you tell me that which is the narrowest part of the middle ear cavity? Narrowest. First question. Second question, which is the smallest part of the middle ear cavity? Yes, narrowest and smallest. Yes, narrowest will be the mesotympanum. Why that is the mesotympanum? Yes, where is the tympanic membrane tented inside? What is that area known as? That is the umbo. At the umbo it is tented inside. And on the medial wall we have a bulge which is known as promontory. So this becomes the narrowest part of the middle ear. And do you know how much is this narrowest in between these two projections? It is only 2 millimeters. Can you imagine? Such narrow. This middle ear cavity that we see appearing to be so big, and we have made the walls and such big diagrams we have made. That is why whenever we have to show the middle ear anatomy to you, now when in your exams it is asked, never will a three-dimensional picture of the middle ear anatomy or something like what we do in the anatomy, a three-dimensional picture of the middle ear anatomy will not help. Why? Because if you just make a room and you make all the openings and all the okay, so we saw narrowest is the mesotympanum, and what is the smallest part of the middle ear cavity? Yes, the smallest is the hypotympanum. The hypotympanum is the smallest. And the mesotympanum is the narrowest. And the largest and the widest is the epitympanum. It is around 6 millimeters. Largest and the widest, that is also only 6 millimeters. So you can imagine how small the middle ear cavity is. So now let us quickly have a look at the endoscopic anatomy of the middle ear cavity. Yes, the endoscopic anatomy, and that is what you're supposed to know. Yes, I'm not going to show you any three-dimensional pictures of the anatomy of the middle ear. Why? Because the three-dimensional pictures that we show, like a room, like a box, all that, even if you understand it very nicely, I think you've already understood all the walls of the middle ear, all the openings and everything very nicely. Those pictures are absolutely different from the real life pictures, and the real life pictures are the ones that are given to you in your exams, the endoscopic picture. The three-dimensional pictures we like to show you where we cannot show you the real images. So where we are able to show you the real endoscopic, why rely on the three-dimensional, which will anyway not help you. So in the inner ear, I have shown you one three-dimensional picture. Why? Because inner ear is something where you cannot enter, and there the endoscopic anatomy cannot be shown, and that is something the endoscopic anatomy will never be asked. So just for understanding, I have shown you the three-dimensional picture. So when you see that three-dimensional picture, then you ask me that middle ear also, if we had the three-dimensional picture, it would have been great. Yes, that would not help you in any way at all, because this what we are going to see is the live, and that is what is asked from you. So you need to actually understand that. If I just show you one wall and I show you this is the adytus, when you actually see the endoscopic anatomy of the middle ear, you will not just be able to identify the adytus unless and until you have identified it there. Yes, so that is why it is very important to see the endoscopic anatomy. That is why every time we have done any wall, I have shown you the endoscopic anatomy of that wall. So let us quickly see the endoscopic anatomy of the middle ear walls and the cavity. Now we are going to see the endoscopic anatomy of the middle ear. Yes, this is a cadaveric dissection that you are going to see. So the patient is lying down. This is the left ear of the patient. So let me orient it to you first. So that is the upper end, that's the superior end, where you are seeing the lateral process of the malleus. That is the handle of the malleus that you are seeing down there. And that is the lower end. Now also please note what is the anterior part. Since this is the left ear, so this here is the posterior part. This is the posterior part, and that is the anterior part. So now that you have oriented to this, let us start
seeing how the structures of the middle ear look endoscopically, and these are the pictures that are shown to you in your exams. So we are having a closer look at the tympanic membrane here. You are seeing the cone of light anteriorly there, the handle of Malleus, and yes, we have given an incision on the external auditory canal skin. We will raise the external auditory canal skin to enter into the middle ear and to see the structures. This incision, when we give while doing the surgeries of the middle ear to repair the ossicular chain, this incision in the external auditory canal skin just few millimeters lateral to the tympanic membrane is what is known as the Rosen's incision, and this flap of the external auditory canal that we are raising along with the tympanic membrane, the curtain of the tympanic membrane that we will raise to enter into the middle ear, that flap is what is known as the tympanomeatal flap. When we want to enter into the middle ear without damaging the tympanic membrane, this is how we enter into the middle ear. So we have reached up till the annulus. Please note that fibrous. Yes, you can note here that is the thick fibrous annulus that we are seeing. Yes, it is being raised from the tympanic sulcus. Please see that groove that you can see. That is the tympanic sulcus that you were seeing. That is the tympanic sulcus, the groove in the tympanic bone where the tympanic annulus fits very tightly. So we are raising the tympanic annulus from over it so that we can raise the whole of the tympanic membrane anteriorly, and we will have a look at the middle ear. So also note that we are entering the middle ear through the posterior part. So the structures that will be visible to us first will be the structures that are present in the posterior part of the middle ear cavity. So please note here, can you see this cord-like structure going from the posterior wall, from the area of the annulus, going anteriorly in between the handle of Malleus, upper end of the handle of Malleus and the incus. That is what is the chorda tympani. So this is the chorda tympani that we are seeing here. And now you are seeing exactly where it passes. Now just see the end of the probe, where the end of the probe is. Yes, so that is the upper end of the handle of Malleus. On the upper end of the handle of Malleus, please see medially is attached the muscle. That is the tensor tympani coming from the process cochlearformis. Yes, so that is the process cochlearformis from which this muscle is coming, the tensor tympani. It arises from the anterior wall, takes a turn at the process cochlearformis, and then runs laterally to attach to the upper end of the handle of Malleus. See, it is being moved and the Malleus moves along with that. Now the probe is in the center. Just see here, that is the promontory. That area is the promontory. Below that, that is the round window, the opening that we are seeing below, that is the round window. And above that, this area is the oval window on which is the present the footplate of stapes. Please note here on the neck of stapes, can you see this muscle going posteriorly to attach to the pyramid-like structure? So that is the pyramid from which is coming the stapedius attaching to the neck of stapes. Now please note here, from the promontory is going a ridge of bone superiorly, that is known as ponticulus, and inferiorly that is subiculum. The area between these two, this is the sinus tympani hidden behind this bulge of the vertical segment of the facial nerve. Now we are going superiorly, we are entering into the Prusac space. Through the Prusac space, we will go into the epitympanum. So please note the boundaries of the Prusac space. Medially is the neck of the Malleus, and laterally is the pars flaccida which we have retracted forward, and inferiorly is the lateral process of the Malleus. So now we have entered into we have opened the Prusac space, and we are putting the probe anteriorly. What will we have anteriorly? Yes, anteriorly down below we will have the opening of the eustachian tube. Yes, and below all that we are seeing is the hypotympanum. So this anterior wall is what is known as the carotid wall because it is separated from the internal carotid by a very thin crest of bone, and any tumors or aneurysms of the carotid the pulsations can be heard very clearly in the ear. So we are seeing the hypotympanum here, the hypotympanic air cells separating the middle ear from the jugular bulb below. We have removed the incus along with the stapes. So this is the head of the stapes, the neck of the stapes, the crura and the footplate of the stapes. That has been removed now along with the incus. So you are now able to see very clearly the oval window which is now exposed. That is the area of the promontory. And yes, below here we have the round window. And now we are going, yes, just have a look here. Above the oval window on the medial wall, yes, this is the horizontal segment of the facial nerve, above which you are seeing the bulge of the lateral semicircular canal. So that is the bulge of the lateral semicircular canal. Now see, note where the probe is. That is on the crest of bone coming from the epitympanum down. This crest of bone is what is known as the cog. It is the landmark for the geniculate ganglion, which is here. From the inner ear, the facial nerve comes, it takes a turn where the geniculate ganglion is present. So in this one picture where we have removed all the ossicles, we are seeing the posterior wall from which we saw the pyramid, and from the pyramid was arising the stapedius, which was attaching to the neck of stapes, which we have removed here. So here what we are seeing, all this is the medial wall. On the medial wall posteriorly we have the oval window from which the stapes has been removed. Below here we have the bulge of the promontory. Below that we have the round window. So here we have the round window opening, and if I have to pass the cochlear implant electrodes, we will pass it through, yes, through the round window into the scala tympani. Now just notice here, from the promontory, I showed that to you before earlier also, that is a crest of bone superiorly and a crest of bone going inferiorly. This is what is known as the ponticulus, and that is what is known as subiculum. In between these two, on the posterior wall, is the area which is known as the hidden area of the middle ear or the sinus tympani. It lies below the pyramid, so it is known as the infrapyramidal recess. And what also you are seeing here is above the oval window is the horizontal or the tympanic segment of the facial nerve. So the facial nerve from the inner ear, as it comes on the medial wall, it takes a turn. That is the turn, the first genu of the facial, on which is present the geniculate ganglion. And the landmark for the first genu is, it lies just above the processus cochleiformis, from which the tensor tympani tendon takes a turn. It arises from where? From the anterior wall. So it takes a turn from the, it winds around the processus cochleiformis, then to run laterally to attach to the upper end of the handle of Malleus. We just saw that where it was. And this first genu lies just below the cog, which is a crest of bone coming from the roof of the middle ear. The roof of the middle ear we know is known as tegmen tympani. And here we have the horizontal part of the facial nerve. Above that we have the bulge of the lateral semicircular canal there. Just below the horizontal part of the facial nerve, this is the oval window which we already saw. Coming to the anterior wall, in the anterior wall below there we have the opening of the eustachian tube, and below we saw the hypotympanic air cells. Just below that was the jugular bulb. So if there is a tumor of the jugular bulb, it can come through the furrow into the middle ear. Any infection of the middle ear through the roof, through the tegmen tympani, can go into the middle cranial fossa, that is the temporal lobe. If it goes posteriorly here we have the mastoid, so we will have the adytus posteriorly. And if it goes anteriorly we have the carotid. We have to be very careful while operating anteriorly, and thankfully infections do not usually go anteriorly. So this is what you have studied so far, and you saw that whenever we read about these, it was appearing like it was a very big room with 6 walls. Can you just see how minute it is? So all these surgeries of the ear, of the middle ear, are done microscopically. These are microscopic surgery under magnification, and what you're seeing now also, this is under magnification that you're seeing. All these structures that are appearing to you so big are actually very minute. The mesotympanum, the distance between the umbo and the promontory that you're seeing here, which is produced by the basal ton of cochlea, and the umbo, that is just 2 millimeters. That is the narrowest part of the middle ear cavity. So I hope this is clear to you now, and if any endoscopic picture is given to you, you will be able to answer that.
And now let us see the anatomy of the mastoid. Yes, the mastoid, we are doing the anatomy separately because this is a very, very important area. This is the area where we are through which we can access the middle ear. This is the area through which we can access the inner ear. This is the area through which we can access the posterior cranial fossa. This is the area through which we can access the endolymphatic sac. And yes, all these are questions that are asked in your exam. So let us see quickly, step by step, try to understand it. And once you understand it, once your mind knows you, that is what you see whenever you see this picture. But yes, for that, you first need to understand. Yes, so be a little patient and try to understand step by step. So here we have the mastoid. Where is the mastoid? This is the mastoid here. We know this is the mastoid tip, and this is the external acoustic meatus, the external opening that we are seeing. So whenever we have to remove disease from the mastoid, what do? We start drilling. Where do we start drilling? We have certain landmarks for that. And you are going to tell me the landmarks? Yes, we have already done that. Tell me the cartilaginous landmark on the pinna. Yes, what is that? That is immediately your finger should go there. Where is that? Yes, the Simba conchae. Just medial to that on the bony part of the mastoid, we have the bony landmark for mastoid antrum. What is that known as? Yes, the Mc-Evans triangle. So why so many landmarks? We have already seen that mastoid is a very important area. It becomes important because all around it are very important structures. Which important structures? Superiorly, we have the dural plate separating it from the dura of the middle cranial fossa. Posteriorly, we have the sinus plate, this bone, which separates it from the sigmoid sinus. Inferiorly, we have the mastoid tip. So we want to do all the surgeries. We want to approach all these structures that I just told you through the mastoid without damaging all the structures. So we have to be very, very clear what these structures are, where these structures are, so that we do not end up damaging them. So let us see. So here, first we start drilling at the Mc-Evans triangle. So quickly, can you tell me what the Mc-Evans triangle boundaries are? Yes, you know most of it, but still I will tell you again. So here we have the superiorly, we have the temporal line. Okay, so this is the temporal line. Temporal line, or you can call it temporal crest. And anteriorly, this is the posterior margin, the bony margin of the external auditory canal. Here we have the external auditory canal, we know that. So this is the posterior boundary of the external auditory canal, the bony margin of the external auditory canal. So anteriorly, so this is the superior boundary. Anterior boundary is the posterior margin. Posterior, this part, yes, margin of the external auditory canal, bony part. Yes, this is the bone that we are seeing, right? The cartilaginous part along with the pinna has been removed in this skull. So bony part. And the third part of this triangle, Mc-Evans triangle, is a tangent that is drawn to this external auditory canal, and this tangent meeting the temporal line. So the third part, or you can say the inferior part, is the tangent. Tangent from the posterior margin of EAC and cutting the or meeting the temporal line. Temporal line. So this area is what is known as the Mc-Evans triangle, or this is also known as the suprameatal triangle. Why suprameatal triangle? Because it is just above the external acoustic meatus. Now here in this area we have another landmark. Yes, just see here. Can you see one spine of bone here? This bone, this spine of bone, this one, this spine of bone, this crest of bone. Yes, this is known as spine of Henle. This is known as spine of Henle. The mastoid antrum lies just behind it. Just behind this is the area of the Mc-Evans triangle. So this is also considered as a landmark for the mastoid antrum, which means that once you have removed the skin, you have given the incision, you have raised the skin, you will see the spine very nicely, and then things will become very easy for you. You know Mc-Evans triangle is just behind that. So then you do not need to draw all these lines. You just know that just behind the spine of Henle is the Mc-Evans triangle where you have to start drilling. So now let us see how we start drilling. So yes, we give a post-oral incision first, and this post-oral incision is what is known as Weil's incision. Weil's incision. Okay, and now what you will do is, after you have given the incision, you will retract the whole of the pinna forward. Yes, so when you retract the whole of the pinna forward, this cartilaginous framework of the pinna does not come on your way to operate either the mastoid or the external auditory canal or the tympanic membrane or the middle ear. So when you have removed the pinna, it will look something like this. When you have retracted the pinna forward, here was the pinna, you have given the incision here, and this whole of the pinna you have retracted. So now in front of you, you will see this bony framework. This bony framework, you will see the mastoid. Definitely there will be the subcutaneous tissue, there will be the muscles over all this area of the mastoid. But yes, you will see this bony opening of the external auditory canal, through which you can easily now go and operate on the middle ear, on the tympanic membrane, on the external auditory canal. Posteriorly, you can operate on the mastoid. So now pinna no more becomes a hindrance to our access to these structures. So this is what we do. We have given the incision. Now see here what we have done. We have retracted the pinna forwards. Can you make out? You have retracted the pinna forwards. So this area is the area of the external auditory canal, and this has been, here pack has been put. That is why you're not able to see it very clearly. When I show you in the surgeries, you will see it very clearly. This is the area of the mastoid, the McEwan's triangle, where the drilling has been started. When for the first time when I saw that, maybe that was during my internship where I was called to assist one of the ENT surgeons, and I saw him doing this, cutting the pinna and retracting it forward. Believe me, it was such scary. I got so scared that, my God, you've removed the pinna completely. What will happen after surgery to this patient? Yes. So I waited to see till the end how they are suturing it back, and now yes, the patient has the pinna back like that. Yes. So this, now we have started drilling and we have reached up till the antrum. We have opened all the mastoid air cells and we can see this big cavity. Still some air cells are left. We will drill that also. So now let me orient you. This part is the superior part. This is the posterior part and this is the inferior part. So this is the mastoid tip area. Here this area is the area of the sigmoid sinus and this is the area of the temporal line. So this is what is known as the dural plate. This plate of bone is what is known as the dural plate. Dural plate. Dural plate, why? Because it is separating the mastoid antrum from the dura of the middle cranial fossa. And this is what is known as, this posteriorly, this is the plate of bone which is separating the mastoid from the sigmoid sinus. So this is what is known as the sinus plate. This is known as sinus plate. And this angle, can you see? This angle in between the dural plate and the sinus plate. This is the area where you have to clear all the mastoid air cells very clearly so that you do not leave behind any disease here. This is what is known as the sinodural angle. This is known as sinodural angle. Okay, let me write it here. This is known as a sinodural angle. Sinodural angle or angle of Cittoli. Yes, this has been asked in your exam. What is angle of Cittoli? It's angle of Cittoli's. Now, before we drill further to see the other structures, let us first try to understand what are the structures that we are going to see when we drill further. So now I have shown this picture to you earlier also when I showed you the schematic diagram, the schematic model of the middle ear. And what I told you is that there are two halls. The anterior hall is the external auditory canal and the posterior hall is the mastoid, and they have a common wall in between. These two halls, this is the anterior hall and this is the posterior hall. These two halls are divided by a common wall in between, and the anterior hall is again divided into two rooms by a curtain. That curtain we call as tympanic membrane. The two rooms, anterior or the lateral room is the external auditory canal and the medial room is the middle ear. So here this is the lateral room, this is the external auditory canal, and this is the curtain of the tympanic membrane that we are seeing. When we go medial to that, this is the medial room, this is the middle ear, and both of them share a common wall. This is the common wall between the external auditory canal and the mastoid, between the middle ear and the mastoid. Is that very clear? Yes. So which means that the posterior wall of the external auditory canal is a common wall between the external auditory canal and the mastoid. The posterior wall of the middle ear is also the common wall between the middle ear and the mastoid. So now we have drilled the mastoid, the posterior hall we have drilled completely. We have reached up to the mastoid antrum. Now I can access the middle ear through the mastoid, yes or no? Yes, because they have a common wall in between them, that is the posterior wall. And if I want to go from the mastoid into the middle ear, I can make a small opening on this posterior wall. Where we make this opening, that opening is made in between the descending part of the facial nerve that I am seeing here. Yes, the chorda tympani and superior is the fossa incudis, and that is the facial recess area that we have seen very beautifully earlier. Yes. So now what I want you to focus is that when we are going, we have drilled the mastoid and we through the mastoid can approach the middle ear. That is wonderful. Now, when we have drilled the whole of the mastoid, what we are seeing is semicircular canals here. Semicircular canals, we are seeing the semicircular canals through the mastoid, through the medial wall of the mastoid. Is that true? Do we see the semicircular canals through the medial wall of the mastoid? Where are the semicircular canals? They are present in the inner ear. Where is the inner ear? Here we have the external canal. Medial to that is the middle ear and medial to that is the inner ear. So, do we see the semicircular canals through the mastoid also, through the medial wall of the mastoid also? Yes, we see that. So now this picture of the inner ear, we have seen so many number of times. Yes, we know that. So now let us see. This is the medial wall of the middle ear. We know that this is the medial wall of the middle ear which acts as a window to the inner ear, and here is the promontory, here is the oval window which we see through it, here is the round window, here is the bulge of lateral semicircular canal, all that we know. Now what we are going to focus on is not the medial wall of the middle ear, but we are going to focus on the mastoid. This is the posterior wall. Yes, where we have the aretas like this, and this here is the mastoid. This is the medial-most wall of the mastoid antrum. Yes, so what we are seeing is that a part of the semicircular canals also project on the medial-most wall of the mastoid antrum. Is that very clear? Yes, towards the inner ear side, this area will be you will see the semicircular canals. So when you start drilling, when you see the semicircular canals, how do you identify? The drill picture is sometimes given to you and it is asked which semicircular canals. If this picture of the inner ear bony labyrinth is given, we know how to identify the semicircular canals. We see the common crus. So one of them is superior, one is posterior. Which one is posterior? The one which is very close to the lateral is the one that is posterior. We know that, right? So when we are going to see the surgical specimen, there usually we are not able to identify the common crus. So how we identify there is, I'm just telling you now, we will then see the surgical picture. So what we are going to see is which is the semicircular canal which is closest to the mastoid. So that will be the posterior. It has been named as posterior semicircular canal because it points posteriorly. Posteriorly where? Towards the mastoid. So that is the posterior semicircular canal, and the one that is very close to it is the lateral semicircular canal. The one that is left, that is a superior semicircular canal. So now whenever you are seeing any semicircular canal, what knowledge you already have by seeing that? Yes, you know that the semicircular canals are present towards the mastoid, towards the posterior part of the middle ear that we have seen. The bulge of the lateral semicircular canal is present above the oval window, and they are present towards the mastoid, which means that, for example, I show you this and I ask you which ear this is. Yes, so if I ask you which ear this is, first you tell me which ear is this? Which ear is this? Is this the right ear or the left ear? So I know that the semicircular canals are present posteriorly towards the mastoid. So this is the posterior part, this will be the anterior part. Anterior part means we will have the pharynx here, we will have the face here. So this is which ear? This is the right ear. Similarly, if I show you this semicircular canal and I ask you that this is the semicircular canals or the inner ear of which ear? Which ear? How do you know? Wherever the semicircular canals are, this is the area posterior. This is the area towards the mastoid. So this is the area which is anterior. Anterior means it is facing the pharynx. Anterior means it is facing the face. It is facing the pharynx. So this means this is posterior, this is anterior. So this becomes which ear? Yes, this becomes the left ear. Now definitely it is not asked from you which ear this is the right ear or left ear. But why I am telling you this is because when I explain to you showing this diagram, and when a picture to you is given, I do not know from where all you do the MCQs, and when you see a picture like this and then you're not able to solve that question. So that is why no matter which ear is given, you should know that if I am seeing the semicircular canals, that is the posterior part. So this is the semicircular canal which is closest to the mastoid. Here, if I have drawn the mastoid here, so the one that is closest to the mastoid, that will be the posterior. The one that is bisecting it or lying very close to it, that will be the lateral. So with this knowledge, let me see whether you are able to identify the semicircular canals or not. Yes, so first we will see this picture. In this picture, are you able to identify which semicircular canals these are? Yes, so this is the mastoid. Closest to the mastoid is which one? Yes, this. So this is the posterior semicircular canal. The one that is very close to it, bisecting it, this is the lateral semicircular canal. The one that is left in this picture, because this is a picture, a very beautiful picture, definitely you are able to make out that this superior semicircular canal is pointing superiorly, hence is the name superior semicircular canal. But in the operative picture, this is how you identify. So now this is the external auditory canal. This is the external auditory canal. Yes, and this is the mastoid. This is the superior part. This is the mastoid tip. So this is the inferior part. So this is superior. This is inferior. I'm just orienting you. This is inferior part. Okay, so now the drilling of the mastoid. Most of the mastoid drilling has been done. Now, why this picture, why I showed you this before is because this is when the patient is standing. But we do not do the surgery when the patient is standing. We make the patient lie down and then see. So, whenever the pictures are given to you in the exam, they are the lying down operative pictures. They are never straight pictures. So don't expect a straight picture. What you will see will be a picture like this. Now let us orient. So this is the external auditory canal. This is the superior part. This is the inferior part. This is the tip. Yes, this is the inferior part. So here, where are you likely to find the semicircular canals? I will mark 1, 2, 3. You tell me where you will find the semicircular canals. When I am drilling further, in which area should I be very careful that I am going to find the semicircular canals there? Okay, tell me. 1, in this area, superiorly and close to the middle ear, close to the here. This is the posterior wall of the external auditory canal, and deeper will be the posterior wall of middle ear. So will I find the semicircular canals superiorly and also close to the middle ear? 1, or second, 2, the tip area, or third here? 3, where? Tell me. Yes, very good. 1. Yes, 1. That will be closer to the middle ear. That will be closer to the inner ear. Yes, and also it will be present superiorly. The superior semicircular canal bulges in the base of skull superiorly in the pitreous part of temporal bone. It has to be in the superior part, not in the mastoid tip area. Yes, so it will be present here. Now let us see whether we are going to see it there or not. Yes, see. See, now we have drilled the mastoid, and where have we found exactly where we were anticipating to find it? We are seeing the semicircular canals here. Now here in this area, when you are seeing the semicircular canals, when you see the semicircular canals, you can make out now that this is the superior part. And you can automatically know this is the inferior part. This is the anterior part, the external acoustic meatus that you are seeing, and this is the sigmoid sinus that you are seeing. This is the posterior part. So is that very clear? Now, can you identify the semicircular canals? Here is a close-up view that I have given you. Can you identify the semicircular canals? Let us see whether you are able to identify. Name, which one is 1? Tell me, what is this 1? Yes? Yes. So we know that the one that is the semicircular canal which is closest to the mastoid is the one that is the posterior semicircular canal. So which one here is closest to the mastoid? This one. This one. So this is the posterior semicircular canal. 1 is the posterior semicircular canal. 2. What is 2? Yes, that is closest. It is bisecting the posterior semicircular canal. So 2 is the lateral semicircular canal. And this one's 3, this is pointing superiorly. This is the one that is left. So it has to be the superior semicircular canal. Is that very, very clear? Yes. Okay, now don't mistake this, and this is one question that you ask me so many number of times. Okay, now yes, this is also one picture that all of you have sent me, and so many number of times you have sent me, what is this, what is this? We are very confused. So what is this? Yes, again, when you're seeing the semicircular canals, you know that where are you seeing the semicircular canals? This is the area of the mastoid that you have opened. Which semicircular canals? So this is the area of the mastoid when you know. So this is the mastoid. This is the mastoid here. Okay, so we automatically, when we are seeing the semicircular canals, we know there is a superior part. So this is the posterior part. Here we are seeing the middle ear. We are seeing the ossicles. So that definitely has to be the anterior part. Yes. So this is the posterior wall where you are seeing the ossicles. The posterior wall of the middle ear has been drilled totally. Usually when we make an opening in the posterior wall of the middle ear to go from the mastoid into the middle ear, we make an opening below. This here is the short pros of incus. Just see, short pros of incus. That is present on the fossa incudis. Yes, like this. So you, through the antrum, you see where the fossa incudis, where the incus is projecting. You do not touch this area of the posterior wall. You make an opening below that, in between the facial nerve, the chorda tympani, that's the branch of the facial that you are seeing here, and superiorly the fossa incudis. Here, what has been done is that this crest of bone also has been removed very nicely. Yes, it has been removed. Should you remove it while operating? If you remove, what will happen? The ossicles will become dislocated. There will be hearing loss that we do not want. Yes, but this is a cadaver So that is why, to show you that area, this has been dissected out. Okay, now tell me which semicircular canals. I am going to mark it and you tell me which semicircular canals. Tell me one. Yes. Tell me two. Yes, so the one that is closest to the mastoid, that is one is the posterior semicircular canal. 2 is the one that is bisecting it, so that is the lateral semicircular canal. And this is the third. 3, this is the superior semicircular canal. Superior semicircular canal. Is that clear? Yes, we are taking so much of time to understand it for the first time. But once you have understood it, I'm sure just to look at it, you will know what it is. So yes, details matter and it is worth giving it time to get it right, because this is going to stay with you, and no matter how it is asked, you will be able to answer it in your exams. So now we are seeing this. This is the posterior part, we know, because I'm seeing the semicircular canals there. This is the anterior part. So this is the area, in the area of the mastoid, I will see these semicircular canals like this. Yes. So just notice one thing here. Are you seeing this is the membranous labyrinth? Are you seeing what is this? The endolymphatic sac. So yes, notice one thing. Where is the endolymphatic sac? Yes, through the mastoid, if I am seeing the semicircular canal, I will be able to approach the endolymphatic sac also through the mastoid, yes or no? So where in that area of the mastoid where I have drilled, where will I locate the endolymphatic sac? To decompress it, we have to decompress the endolymphatic sac in Meniere's. So how do we decompress it? Don't think endolymphatic sac, we have to decompress it, is going to be a very major surgery. No. This is the same surgery that you do to remove disease from the mastoid. Just the same surgery. All you have to do is you have to drill the bone over the endolymphatic sac also, so that it gets decompressed. Decompress means pressure over it is relieved. So how do you do that? Yes, so where do you find it? You first need to know. So where will you find it? What you will do is you will draw a line from the lateral semicircular canal which bisects the posterior semicircular canal, and this endolymphatic sac you will find below this. This line is what is known as Donaldson's line. Donaldson's line. Donaldson's line. It is from the lateral semicircular canal to the posterior semicircular canal, and the endolymphatic sac lies below it. So this is the imaginary line. Don't start looking for some line there. It is the imaginary line below it. So here, where will you find the endolymphatic sac? When you have drilled the mastoid, where am I going to find the endolymphatic sac? Here? Yes or no? No. So I am going to first identify the semicircular canals. Yes. So these are the, this is the closest to the mastoid. So this is posterior, and bisecting it, this is the lateral. So now I am going to draw imaginary line from the lateral bisecting the posterior. This is what we call as Donaldson's line, and I am going to find the endolymphatic sac somewhere here. So this area of the bone, if I remove, what surgery have I done? I have decompressed the endolymphatic sac. Have you understood that? So here, let me see here. So where will you drill to decompress the endolymphatic sac? So now immediately when we have a look at this mastoid, we know so much about it already. What? We know that this is the superior part because we are seeing the semicircular canals here. Yes, and this is the inferior part. We are seeing the external artery canal, that is, and this is the anterior part. And where we are seeing the sinus, that is the posterior part. Which semicircular canal? This is the posterior, this is lateral, and this is superior. We already know it. Now I am going to draw imaginary line, and this is Donaldson's line, and this is the area where if I drill, I will find the endolymphatic sac. Where is the endolymphatic sac present? Is it present intradurally? Do I have to drill and then open the dura to see the endolymphatic sac? No. Endolymphatic sac, where is it present? I have showed you earlier also. So we have the the parts of the brain here. This is the skull overlying it. Let me make it like this, and we know that this is endolymphatic sac. This is the area of the posterior cranial fossa. So that is why let me draw it like this here in the posterior cranial fossa. Okay. So we have the meningeal layers. What are the layers of the meninges? We have the pia. Then we have the arachnoid. And then we have the dura. The dura in this area has two layers. One is the meningeal layer that is very tightly attached to the brain, and the other is the endosteal layer. Endosteal layer is very tightly attached to the skull. So where is the endolymphatic sac present? It is present in between these two. So it is present
intradurally. It is present intradurally, or we can say that it lies over the dura of the posterior cranial fossa. Which dura am I talking about? The meningeal layer of the dura of the posterior cranial fossa. So this is when I just drill here, the bone when I am removing, automatically along with the bone comes gets removed the endosteal layer of the dura, and I am directly on the meninges, that is the endolymphatic sac I can see, which is lying over the meninges, or I can say lying over the dura of the posterior cranial fossa. So this is the endolymphatic sac area. Also we know that till now what we know is that when we drill the mastoid, when we have reached the medialmost wall of the antrum, what all can we approach? We can approach the middle ear through it. Yes or no? Yes, from here we can introduce electrodes of cochlear implant into the middle ear. We can remove disease from the middle ear. Yes or no? Yes. Second, we can also approach the inner ear through it. Yes or no? Yes. Third, we can approach the endolymphatic sac through it. Yes or no? Yes. Fourth, we can also approach the posterior cranial fossa. This is lying on the posterior cranial fossa. We know that, yes. This is lying on the posterior cranial fossa. See here. Here what we are seeing is, we are seeing the semicircular canals here. These are the semicircular canals. Yes, this one is closest to the mastoid. That is the posterior, and this is the lateral semicircular canal. So here, when we draw a line, that is the Donaldson's line, I will find the endolymphatic sac here lying on the dura of the posterior cranial fossa, which means that what is that area? This is the area of the posterior cranial fossa. This all is the area of the posterior cranial fossa. So through the mastoid, you can also approach the posterior cranial fossa to remove tumors from that. And just imagine, that would be such an easy approach to approach the posterior cranial fossa through the mastoid, because mastoid surgeries we do so commonly. So if you can approach the posterior cranial fossa also through it, that would be so easy. You do not have to do an intracranial surgery to remove that. Through here you can easily approach. Okay, but now what we know is that when we have to remove the disease from the posterior cranial fossa, when we have to remove a tumor from the posterior cranial fossa, it is better to approach above the Donaldson's line. Why above the Donaldson's line? Because just below that will be endolymphatic sac. Why damage it? If you damage the endolymphatic sac, inner ear will be affected. Yes or no? So that it does not come on our way, we are totally not worried about it. What we do is that we draw this imaginary line and we approach the posterior cranial fossa above this line. Above this line. Is that clear? So this line, this above this line, this area is what is known as the Trotman's triangle. Trotman's triangle. Yes, so what is Trotman's triangle? It is the area on the medial wall of the mastoid antrum through which we enter into the posterior cranial fossa. What are the boundaries of this Trotman's triangle? Just see here. Posterior we already know. It will be the sigmoid sinus. Sigmoid sinus. This is sigmoid sinus. Yes. Superiorly, we have the tributary of the sigmoid sinus. This is the superior petrosal sinus. This is the superior petrosal sinus, and anteriorly what do we have? Anteriorly is the inner ear. Anteriorly is the bony labyrinth. So if I write down the boundaries of the Trotman's triangle, posteriorly, yes, tell me what will be posteriorly? Posteriorly will be the sigmoid sinus. Anteriorly, what will be anteriorly? Anteriorly will be the inner ear, and superiorly will be the superior petrosal sinus. Superior petrosal sinus, have you heard about it? Is it a tributary of the sigmoid sinus? Yes, superior petrosal sinus. Is that very clear? So now when we have a look at this picture, now that all the drilling we have done of our brains, yes, I think drilling of mastoid is easier than drilling of our brain. So anyway, we have drilled and we have reached and we have removed all the disease from there and we have put everything, all the knowledge there. So now when we are looking at this mastoid, can you just see it and you know everything? You have drilled, you have removed the disease. Now when you are drilling further, you know that which area is very important for the semicircular canals. You should not drill too much in that area unless and until you want to enter into the inner ear. Yes, which is the area which you do not want to drill if you do not want to damage the sigmoid sinus. Which is the area you do not want to drill if you do not want to damage the facial nerve. Yes, so yes, we have the facial nerve here also.
Here also, and at the tip area also where it is coming down. This vertical segment only comes down to exit through the stylomastoid foramen. Here we have the sigmoid sinus. This is the area of the semicircular canals. Which semicircular canal you know very nicely till now. Yes, this is the area of the roof of the mastoid. The roof of the mastoid, the roof of the middle ear, what is that known as? Tegmen tympani. Roof of the mastoid is what is known as tegmen antri. Tegmen antri. Okay, and which is the area if you are operating for removing disease of the posterior cranial fossa, tumor of the posterior cranial fossa, you will have to first drill it like this. Drill it like this so that you are able to see the semicircular canals very nicely. You do not want to remove the posterior cranial fossa tumor and after that give the patient a dead ear, that everything of the ear you have damaged. No. So you will have to first skeletonize the semicircular canals. Okay, you have seen that is safe. So you will go enter into the posterior cranial fossa behind it, posterior to it. Yes, and also posteriorly you cannot go so much posterior also. Okay, all this is posterior cranial fossa, let me drill everywhere. No, we know that posteriorly we can go only till the sigmoid sinus because then you will be injuring. So you will make a window here, an opening here through which you can enter and approach the posterior cranial fossa. That area is what is known as Trotman's triangle. So do you know the Trotman's triangle? Do you know the Donaldson's line? Do you know where you will drill to decompass the endolymphatic sac? Yes. Can you identify the semicircular canals when you see the mastoid? Do you know first of all where to start drilling the mastoid when you are making the patient lie down and giving the incision? The McEwen's triangle, where exactly you know to find the McEwen's triangle? Yes, so you know all that now. Quickly tell me the boundaries of the McEwen's triangle. Boundaries of McEwen's triangle. Yes. Superiorly, temporal line. Anteriorly, yes, the posterior superior margin of bony external auditory canal. And third is a tangent. Can you tell me what is the City's angle? Yes, the sinodural angle. Sinodural angle. Tell me the boundaries of Trotman's triangle. Trotman's triangle. Anteriorly, inner ear, bony labyrinth. Posteriorly, sigmoid sinus. Superiorly, tributary of the sigmoid sinus, superior petrosal sinus. Yes, and Donaldson's line, it's the imaginary line between, you draw bisecting, yes, the lateral semicircular canal bisecting the posterior semicircular canal. Where do you find the endolymphatic sac? Inferior to it, superior to it? Inferior to it, inferior to it. So that is what you need to know about the anatomy of the mastoid.